Alright guys, today we're going to go over Chapter 11, go over baseline vitals, monitoring the device, and how we take a history. In this chapter we're going to go over patient information that needs to be gathered, some equipment that we use to monitor vitals, as well as preparing what you need to do to prepare to take a patient history, as well as taking the history. Patient assessment is a skill that every EMT has to provide to every patient. This assessment is what we use to determine what is wrong with our patient and determine what kind of care we need to provide. And measuring vital signs is a key part of that because it helps reveal trends in the patient's condition on whether they are improving or continuing to deteriorate. Also, we need to know what the patient's history is so that way we know any underlying problems that they may or may not have. Much of the information you gain during assessment is readily obvious or available. An open bottle of bleach may provide the clue to a poisoning. The patient or family member may tell you the chief complaint, for example, "I can't catch my breath," or "I hurt my leg when I fell." The fact that the patient is answering questions clearly may tell you that they are alert, have an open airway, are breathing adequately, and have a pulse. Correctly reading and interpreting vital signs significantly affects the success of pre-hospital emergency care and the critical information you provide the hospital staff. Taking two or more sets of vital signs and comparing them will reveal changes in the patient's condition and may indicate how effectively you are managing the patient's injury or illness, or if the patient is deteriorating. So we want to make sure that we assess respirations, pulse, skin condition, color, and temperature, pupil reactivity, blood pressure, and pulse oximetry. As an example, a blood pressure that continues to decrease and a heart rate that continues to increase are significant findings in a patient who you suspect is losing blood. So make sure that you review the equipment carried and routinely used for patient monitoring. Coffee's cold. First, look at the patient and determine whether they look to be in respiratory distress. Second, assess their mental status and pay attention to their speech pattern. The respiratory rate is then assessed by observing the patient's chest rise and fall. If you encounter a patient with a respiratory rate of 8, who is alert, oriented, and able to answer your questions without gasping for a breath or showing a struggle to breathe, 8 may be their normal respiratory rate, and no interventions is necessary. On the other hand, if the patient has their eyes closed, needs to be aroused with verbal stimuli, appears fatigued, appears to be struggling to breathe, or speaks only a couple of words before gasping for a breath, you would consider assisting the patient's ventilation. Table 11-1 in your book goes over various respiratory rates that would be normal for a patient, such as an adult being 12 to 20, toddler 22 to 37, school-age children being 18 to 25. I would recommend looking over this table and having an understanding of it for when you come across these patients. If the patient knows you are counting, it can potentially influence the rate. Instead, pretend to check the radial pulse and cross the patient's arm over the lower chest while counting respirations. Determining quality of respiration or breathing is as important as determining rate. It tells you the volume of air moving in and out of the lungs with each breath, the volume per minute, and how well it is moving. If either the respiratory rate or the tidal volume is found to be inadequate, then the patient's respiratory status is inadequate and positive pressure ventilation must be initiated. You can assess the quality of respirations while you're counting the rate. You can have a normal quality or shallow. When you go to assess this, you're going to see minimal to no chest rise. Labored quality would be, for example, you'll start seeing accessory muscle usage. Noisy respirations, this is when you'll start hearing those sub-sounds such as stridor or wheezing or crackle, something along those lines. You also want to determine what the rhythm of the respiratory pattern is on whether or not it is a regular or irregular respiratory pattern. An abnormal regularity in pattern with an altered mental status is a serious condition. You can have various patterns such as Cheyenne-Stokes, which is when the respiratory rate and tidal volume gradually increase and gradually decrease, followed by a period of apnea for up to 10 seconds. The pattern then would repeat itself. Biot, which is similar to Cheyenne-Stokes, except that the tidal volume does not change, but the respiratory pattern is interrupted by a period of apnea. Apneustic, this is characterized by prolonged periods of inhalation, whereas ataxic is an irregular pattern of rate and tidal volume. Agonal is long periods of apnea with a gasping breath interposed. Kussmaul is a rapid respiratory rate with a deep and labored tidal volume, and central neurogenic hyperventilation is a sustained deep and rapid respiratory rate of at least 25 breaths per minute, however with a regular pattern. Table 11-2 goes over some different noises that you may hear upon respiration. Sounds that you can hear without a stethoscope would be snoring or gurgling, which is indicative of some type of obstruction or fluid within the airway. Shudder or coring would indicate partial obstruction of the upper airway around the level of the larynx. With a stethoscope, you can hear sounds such as wheezing or crackles or rhonchi. Wheezing being constriction and inflammation within the bronchioles, crackles being fluid surrounding and filling the alveoli, and rhonchi, which is mucus blocking the larger bronchioles. Pulse, you need to be able to ensure that you are able to assess for a pulse, because you are measuring the amount of pressure, the pressure wave generated by the contraction of the left ventricle. This is able to directly reflect what the heart function of the body is. You need to make sure that you're able to assess for the rhythm of the pulse to determine whether or not the patient has a regular or irregular pulse, as well as determining whether it is a bounding, where it feels very strong, a regular pulse, or a weak and thready pulse. There are a variety of pulses points that we will assess for. All of these points are along a major bone because you are compressing the artery between your fingers and the bone. Your carotid can be found on either side of the neck. Your femoral artery can be found in the crease between the lower abdomen and the upper thigh in your groin area. If you're checking for the femoral, you are going to have to push very deep to get underneath your femoral muscles. The radial artery is found proximal to the thumb on the palmar side of your patient's wrist. Your brachial artery is found on the medial aspect of the arm, midway between the shoulder and the elbow, between the bicep and tricep muscles. You will have to laterally displace the brachial muscle in order to feel this pulse. The popliteal artery can be found in the crease behind the knee. The posterior tibial artery is found behind the medial malleolus or the ankle bone. And the dorsalis pedis is found on the top of the foot on the great toe side. When palpating your carotid pulse, make sure not to compress too hard because this could impede circulation to the brain. Never assess the carotid pulse on both sides at the same time, and avoid excessive pressure in elderly patients. If checking the pulse on a patient greater than 1, start with checking the radial pulse. If they are 1 year or older without a peripheral pulse, check the carotid pulse next, and if they are less than 1 year of age, check the brachial. In the adult patient, a heart rate greater than 100 beats per minute is termed tachycardia, and a heart rate less than 60 is called bradycardia. Any adult heart rate that is less than 45 beats per minute or greater than 130 beats per minute is typically an indication of a severe illness or injury. A heart rate less than 100 beats per minute in the neonate is neonatal bradycardia. The heart rate must be considered in relation to the patient's presentation and assessment findings. A heart rate that falls within the limits of 60 to 100 could be considered abnormal for some patients, depending on medications that they may be on, whereas a heart rate falling outside of these limits could be considered normal. As an example, a resting heart rate of 42 is obtained for a 34-year-old male patient who injured his ankle. The patient appears to be physically fit and presents as alert, oriented, and showing no signs of poor perfusion. Although the heart rate is only 42 and would be reported as bradycardic, it would not be cause for alarm based on the patient's presentation. Another example, a heart rate of 92 in an elderly patient at rest would be considered normal. However, a heart rate of 92 in a 20-year-old at rest may be a cause for concern, even though it falls within the definition of a normal range and is not tachycardic. Table 11-3 goes over some normal ranges for heart rate per minute, which is such as for a neonate 100 to 205, preschooler 80 to 120, and an adult 60 to 100. To obtain a pulse, you want to first locate the pulse. Your patient should either be sitting or lying down. You want to use the tips of 2 to 3 fingers, but do not use your thumb because it does have a pulse of its own. Palpate the artery and count the number of beats in a 15 to 30 second period, then multiply 2 for 30 seconds or 4 for 15 seconds. If you palpate an irregular pulse, it should be taken for a full minute. This can help you gauge your patient's condition. For example, a rapid pulse may indicate shock. Absence of a pulse indicates that the heart has stopped beating or the blood pressure is extremely low. Absence of a pulse in a single extremity may indicate obstruction to the artery in that extremity and may be associated with bone or joint injuries. Pulse characteristics are defined as follows. You may have a strong pulse, which is a pulse that is both full and normally strong, whereas a bounding pulse is one that is abnormally strong. A weak pulse is one that doesn't feel full or may be difficult to find and palpate. A weak pulse may also be quite rapid, which would be termed thready. A regular pulse is one that is occurring at normal intervals with a smooth rhythm. An irregular pulse is a pulse that occurs at irregular intervals, which may indicate a cardiac disease. An irregular pulse can be regularly irregular or irregularly irregular. A regular irregular pulse is one in which the irregular beat occurs at a regular interval and has a pattern. An example is an abnormal beat that occurs early after each fourth regular beat. An irregular pulse has no predictable pattern and presents as a chaotic rhythm. Table 11-4 goes over various pulse rates, the quality, rhythm, and related problems that you may come across, such as a slow pulse could be caused by narcotic use or head injury, or such medical conditions such as hypothyroidism. Next, you want to, at the same time as checking the pulse, you can also assess the skin and determine the appearance and condition of the skin, looking for the color, temperature, condition, as well as capillary refill. With skin color, you want to check for paleness or pallor. This would be a sign of extreme vasoconstriction, blood loss, or both. It may indicate shock, a patient who's having a heart attack, fainted, or emotional distress. Pale, cool, and clammy skin may be an early sign of inadequate oxygenation, hypoxia, and hypoxemia. Cyanosis, or a blue-gray color, is an indication of inadequate oxygenation or poor perfusion. It often appears first within the fingertips and around the mouth, which is referred to as circumoral cyanosis. It can indicate conditions such as suffocation, inadequate respirations, hypoxia, hypoxemia, heart attack, or poisoning. Cyanosis always indicates a serious problem, but is often seen very late. Flushing, or red color of the skin, would be sign of heat exposure, peripheral vasodilation, or a very light finding in carbon monoxide poisoning. Jaundice, or a yellow color would be indicative of liver disease. And mottling is a discoloration similar to cyanosis. However, it occurs as a blotchy pattern. Mottled skin may be seen in some shock patients or patients with blood pooling in the extremities for a long period of time. Changes in skin temperature over a period of time, or different temperatures in various parts of the body, can be significant. For example, circulatory problems can result in a cold foot, whereas an isolated hot area may indicate a localized infection. Direct sympathetic nervous stimulation and circulating epinephrine and norepinephrine will cause the vessels in the skin to constrict, shunting the warm red blood away from the skin, which causes the skin to become cool and pale. The nerves and alpha properties of epinephrine and norepi will stimulate the sweat glands, making the skin clammy or moist, or making the patient diaphoretic. Also, if the skin is abnormally dry, this would be a sign of either severe dehydration or of spinal injury. The time it takes for compressed capillaries to fill up again with blood is called capillary refill time. It is a more reliable sign in infants and younger children than in older children or adults, because younger children usually have very little existing diseases that might affect the perfusion in capillaries. When assessing the capillary refill, you will squeeze the finger and watch the amount of time that it takes for the capillaries to fill up. Normal refill time in infants, children, and male adults is 2 seconds. In females, 3 seconds, and in the elderly, up to 4 seconds. Table 11-5 in your book goes over appearance and conditions of the skin, the temperature and condition, as well as problems that potentially could be causing it. I would recommend looking over this table in your book. Pupils, when assessing these, you want to not only determine the reaction of the pupils, but also the size, equality, and reactivity. Make sure that you're using a pen light and not extremely bright flashlight due to the risk of causing damage to the eyes. You want to assess the eyes. Are they dilated? This could indicate that use of certain drugs, including amphetamines, atropine, and cocaine. Pupils that are constricted may indicate a central nervous system disorder or the use of narcotics, glaucoma medications, or a brightly lit environment. You also want to assess for equality, because pupils of unequal size may indicate a stroke, head injury, an artificial eye, disease of the eye, use of certain eye drops, or injury to the eye or nerve that control the pupils. Some people normally do have unequal pupils. If it is a normal condition, however, the pupils remain reactive to light and the size difference is not great. This condition is termed anisocoria. It may be due to a congenital defect or an ophthalmic injury. Many patients with a difference of 1 millimeter or less between pupil sizes are simply considered normal without underlying disease or injury. Reactivity refers to the pupil changing in size in response to light shined in the eye. The pupils, which are normally mid-sized, constrict when light is shined in them. The pupils dilate when shaded or in a dark environment. Both pupils have the same response even when the light is shined in only one eye. This is called a consensual reflex. For example, you shine a light in the right eye, and the right eye and left eye pupil constrict simultaneously. Pupils that remain mid-sized may indicate cranial nerve damage. So you want to assess for constricted pupils, dilated pupils, or unequal pupils. Table 11-6 goes over factors or pupil size and potential problems that you may come across, such as dilated eyes may indicate cardiac arrest. In this case, pupils will also be fixed and non-reactive. When the left ventricle of the heart contracts, it ejects blood into the aorta and throughout the arteries of the body. The pressure that is exerted on the walls of the arteries by the blood flowing through them is referred to as the blood pressure. The blood pressure normally includes 2 readings: the systolic blood pressure and the diastolic blood pressure measured in millimeters of mercury. Table 11-7 goes over some various blood pressures that you will see in adults, infants, and children. Blood pressures vary widely for different patients. A normal systolic blood pressure in an adult is less than 120 millimeters of mercury. A normal diastolic is less than 80. However, you want to take the patient's medical history into consideration when assessing this, because for some patients with hypertension, a elevated blood pressure may be normal for them. Table 11-8 goes over blood pressures indicating hypotension depending on age. In adults, it's less than 90 is when we start considering a patient to be hypotensive, whereas in infants it would be less than 60. In children, it would be less than 70 plus 2 times the year of age. So if they are 5 years old, it would be less than 80. Pulse pressure, this is the difference between a patient's systolic pressure and diastolic pressure. This should be between 25 and 50% of the systolic blood pressure. For example, if their blood pressure is 124 over 80, the pulse pressure would be 44, because 124 minus 80 equals 44. So if the pulse pressure is less than 25% of the systolic blood pressure, it would be considered a narrow pulse. If the pulse pressure is greater than 50% of the systolic blood pressure, it would be considered a widened pulse pressure. So in order for it to be considered a narrow pulse pressure, it would need to be less than 31, which is 124 times 0.25. And a widened pulse pressure would be greater than 62 because 124 times 0.5 equals 62 millimeters of mercury. Now you need to be able to determine what this is, because depending on various conditions, and we'll go over these later on in our lectures, some of the signs and symptoms that you will see is a narrow or widened pulse pressure. A low blood pressure indicates that there is not enough pressure within the arteries to keep the organ supplied with an adequate amount of blood. In an adult patient, a systolic blood pressure of less than 90 is typically considered to be low, although this is somewhat variable and should be considered in the context of the patient's condition. High blood pressure, also known as hypertension, can result from a variety of causes. The abnormally high blood pressure can cause damage to the heart and blood vessels, leading to heart damage and failure, stroke, ruptured blood vessels, and kidney disease. It is difficult to assess blood pressure in infants and children less than 3 years of age. Therefore, you may need to rely on the skin temperature, color, and condition, your patient's mental status, and quality of locations of pulses to determine the perfusion status. To assess blood pressure, we do it through one of two ways. We either auscultate by listening through a stethoscope for the systolic and diastolic sounds. When auscultating, you'll increase the pressure within your blood pressure cuff to the point that you no longer hear the pulse, and then slowly come back down. When you start hearing the pulse again, this is your systolic blood pressure. When you stop hearing it, that is your diastolic blood pressure. When palpating a pulse, same premise, you'll increase the blood pressure cuff until you no longer feel a radial pulse. You will then start coming back down. When you get to the point that you start feeling the radial pulse again, that is your systolic blood pressure. You cannot get a diastolic while palpating a pulse. When checking for a blood pressure, make sure that you don't keep it on too long, because this can cause issues in your patient. Also, make sure that you are supporting the arm and have the position in a relaxed position, because placing strain on the arm, or the patient placing strain on the arm, may change your blood pressure reading. In a patient that we suspect volume loss, you may be asked to obtain a set of vital signs called orthostatic vital signs, or a tilt test. This is done by placing the patient in a supine position and measuring their blood pressure and heart rate, then standing them up, and after 2 minutes reassessing blood pressure and pulse. If while the patient is standing your heart rate increases by greater than 10 to 20 and the systolic blood pressure decreases by 10 to 20, as compared to the readings taken while the patient was supine, it is a positive orthostatic test, which typically indicates a significant loss of blood or fluid volume. The orthostatic vital signs test is also commonly known as the tilt test. Next. If your patient is stable, vital signs should be taken and recorded at least every 15 minutes and as often as necessary to ensure proper care. Take and record every vital signs every 5 minutes if your patient is unstable. Then reassess vital signs immediately following every medical intervention, regardless of how soon it follows your previous assessment of vital signs. Pulse oximetry is a method of measuring oxygen saturations within the blood. The device used to measure the level of hemoglobin saturated with oxygen is a pulse oximeter. Because it is used to determine the patient's oxygenation status, it should be applied early within your assessment, preferably in the primary assessment. An SpO2 reading of 90% or less is a definite indication of hypoxia. Assess your patient carefully, paying close attention to the respiratory rate and tidal volume. They may need to be ventilated if either the rate or tidal volume is found to be inadequate. Whether the patient requires assisted ventilation or not, apply oxygen to the patient. Be aggressive in your management of the patient, bearing in mind that the result of severe and prolonged hypoxia is cell death. If the patient receives supplemental oxygen and the pulse oximeter reading is near or slightly greater than 94%, sorry about that, guys. Where was I? Oh yeah. If the patient receiving supplemental oxygen and the pulse ox reading is near or slightly greater than 94, it may still be an indication that the patient is hypoxic. If the supplemental oxygen is removed, the reading may decrease to less than 94% again. Pulse ox needs a pulsatile arterial blood flow to determine an accurate reading. Any condition that interferes with the blood flowing to the area where the probe is attached may produce an erroneous reading. Your pulse ox must be used appropriately because erroneous readings provide false information and may adversely affect your treatment. Alright guys, we're gonna take a break here. Y'all take a break, stretch your legs, use the restroom, get something to drink, and we will come back and pick up with limitations of the pulse oximeter.